Yeah, so the subtitle, Sisyphus or Odysseus. So Sisyphus in mythology is the guy who keeps rolling the stone up the hill, and it keeps rolling back on him, and it's a sort of fruitless effort. Where Odysseus went and fought the Trojan War for 10 years, and then it took him another 10 years to get back home. So he had a lot of flight cancellations and layovers along the way, but he eventually got back home. So I'll return to this slide at the end. I'm not going to have much in the background of chronic pain. There was an IOM report 8 years ago now, which showed how prevalent it was and what the cost was. Another point I like to make is the disability. There's a metric called years lived with disability, which has to do with how common a disease is, how many years people live with, and how disabling it is. So actually diseases that kill you quickly don't cause a lot of years lived with disability. If you look at the 12 leading medical causes among top 30, they're here, and in parentheses is their number on the list. So like COPD is the 6th most common disorder that causes years lived with disability. And collectively, these 12 disorders, medical diseases, cause 8.3 million years lived with disability. In contrast, if you look at the 5 leading pain conditions, you can see 4 of the top 9 are chronic musculoskeletal pain condition, and together they account for more years lived with disability than the 12 leading medical causes. If you add depression and anxiety, which co-occurs in 30 to 50% of people with chronic pain, you got a bunch of years lived with disability. This is the quantitative piece. So I'll close my evidence with a qualitative piece. So Emily Dickinson wrote a poem which says pain cannot recollect when it began, or if there was a time when it was not, it has no future but itself. So pretty elegant qualitative quote. So the points I'm going to make in about the next 15 to 17 minutes, because I do want to leave 5 to 10 minutes at the end for questions. I'm going to make some points that are about clinical issues, some about policy, and some about research. That's true of anything we study. It has all of these. But boy, is it true of chronic pain and opiates nowadays. It's hard to talk about one without talking about the other. The first thing you have to understand is treatment for chronic pain is just not that great. Every single treatment has a modest benefit, and I'll use a stack of quarters analogy. So a quarter doesn't buy you much. Maybe a stack of 10 quarters buys you a bottled water among the economy. Now, if you add another stack of quarters, you at least get $5 of benefit. The only choice we have with treatments generally is we either increase the dose, so we increase the number of quarters in a stack, we switch treatments, we switch to another stack, or we combine treatments and we get $5 worth of treatment. That's not that different from many medical diseases we treat, where we often combine medications, non-pharmacological treatments to get the optimal benefit. So I'm going to talk a few clinical points about medications more than non-pharmacologic, but I think at the end of the day, we need both on our menu. So if you want to look how effective drugs are, and you want to look at back pain, which tends to be number 1 on the list, and in fact, we don't know how much from back pain generalizes to other treatments, like neck pain and arthritis and things like that, but it probably does. And the fact is, there's been a lot of research done in a few pain conditions. Now, this was a review in Annals by Roger Chow, and what you should notice is there's only 3 treatments that have a small effect, and on the next slide, I'll show you what small means, and that's NSAIDs, opiates, and a few trials on duloxetine. Look at all the things that when you do placebo-controlled trials don't seem to affect back pain. Things like acetaminophen and antidepressants and other categories of agents. Muscle relaxants have only effect in acute pain. It's not been evidence-based in chronic. So I'll show you another slide looking at this in a different way. Are systematic reviews of the literature where they normalize things to a 0 to 100 point pain scale. So 0 means no pain, 100 means the worst pain you can imagine. There's also 0 to 10. But if you normalize 0 to 100, you just remember the number 10 points is clinically important. There's 4 classes of drugs. The number in parentheses is the number of trials done. So for example, NSAIDs has had 13 placebo-controlled trials for back pain and 9 for osteoarthritis. And you can see the number next most commonly studied is opiates. Acetaminophen's had a lot more for arthritis, 10, and only 3 for low back pain. So the only 2 effective ones are NSAIDs and opiates. And they both have a half of a clinically significant effect, probably a small effect size compared to placebo. So I want to spend a few slides because we cannot ignore the issue of opiates. We've heard a lot of problems with opiates, which are really important to recognize. I just want to have a couple of slides on the epidemiology of the risk in people prescribed opiates. And so there's really 3 major issues. I talk about 2 on this slide. One is, do you become a chronic user when you get a prescription? The second, do you develop an opiate use disorder, which means you become addicted to it, OUD? And the next slide, do you die? Do you get an overdose? Well, this is a series of studies that have looked at the prevalence of 2 of these. You can see some are large database studies. All of them are large database studies, largely somewhat different populations. I want to focus on the last 2 columns. On average, about 1 in 20 who get an initial prescription for an opiate will use it for more than 90 days. And that's important. Also, 19 out of 20 don't, okay? 1 out of 200 will develop an opiate use disorder, become addicted to it, and that's important. 199 out of 200 don't, okay? So I'm just trying to put in perspective a lot of the epidemiology we hear now. The really big one is opiate-related mortality. Huge, enormous issue in this country, becoming leading cause of mortality among young and middle-aged adults, 20,000 per year. Now, what's happened in the last 5 years is there's been a switch from prescribed opiates, which is plateaued, and now illicit opiates. But a lot of people say prescribed opiates kindle the fire, which is true. It's at least 50% true. What's the risk if you're prescribed opiate and related to the dose? And this is compared to people on very low doses. So if you're on a medium dose, which is about 50 morphine milliequivalents, about 1 out of 667 individuals may experience an opiate overdose. And if you're in a higher dose, it's about 1 out of 400. So this is the worst thing that could happen, and it's terrible. The risk within an individual who's prescribed opiates is quite small. So there's 2 perspectives out there. What's the overlap between chronic pain, including patients on opiates, and opiate addiction? Okay. If you work in primary care, you probably think it's more like B. If you work in an addiction clinic, it's probably more like A. We actually don't know. The experience from people who work in primary care tends to be, it's probably closer to B than A, but we don't know, because when people are on opiates, it's really hard to say whether they're addicted until you take them off. I'm just saying that this is a little bit of the problem of the epidemiology. And so there has been this pendulum. So in the 1990s, we were encouraged to prescribe opiates. And so 0 means we shouldn't give opiates to anybody. 10 means we should use them to treat chronic pain. And there was a push towards this right side of the pendulum. In 2016, we started hearing about this terrible opiate crisis out there, and it's being treated like a plague that must be eradicated, even at the cost of persistent pain. So I'm going to show you one other thing, because I'm going to show one slide on a consensus report we were involved in on issues in terms of implementing the CDC guidelines. And that had 14 experts on it. And most people are between 2 and 4, because nobody out there says we should even be a 5. We should be much more reluctant to prescribe opiates in the future. A 0 would be almost never prescribed. But that difference between 2 and 4 on the panel was quite important, because the 2s believe we should move towards universal discontinuation, if at all possible, in anybody on chronic opiates. Whereas the 4s mean we should have many fewer starts than we did in the past, but the 10 to 18 million Americans on opiates for chronic pain we have to sort of say, what kind of approach do we take? And that's a real bone of contention currently. Now, what about the Opioid Guideline? So that came out, and a few years back, the CDC came out with a guideline. And what's happened is they've been treated as the 10 commandments. There's actually 12, so it'd be the 12 commandments. They have 12 recommendations. And they never intended it to be scripture. They intended it to be a guideline. And what's happened is there have been some issues in terms of implementing the guidelines. And so the other thing I wanted to indicate is in the last couple years since that's happened, we had written a piece a couple years ago about where are we now? How do we handle, especially the people on chronic opiates? And others have written since. New England Journal had a piece the same year, The Other Victims of the Opiate Epidemic, which are people with chronic pain. A couple of weeks ago, the New York Times had an op-ed piece, When the Cure is Worse Than the Disease, and they talk about people with chronic pain being withdrawn from opiates. And then even the Human Rights Watch has an 80-page document on not allowed to be compassionate, but they talk about the chronic pain patient who may be on opiates, who's unilaterally getting discontinued. And so this slide says too many people are dying. The situation's out of control. I kind of thought they were helping you, but right now you have to stop your Lortab. And what did I do? So there's this concept of the chronic pain patient. And again, I think we have two cohorts. We have the cohort moving forward of chronic pain, where we're going to prescribe very few opiates in the future, and we'll reserve opiates to a limited role in other cases, end-of-life pain, maybe severe trauma and so forth. And then we have a residual cohort of about 10 to 15 million Americans on opiates for chronic pain. So there was a task force, a work group from the American Academy of Pain Medicine that convened about a year and a half ago, and I said there were 14 experts on it. About 5 of them were, to 6 of them were 2 on the scale. They believed we should withdraw more people, and about the other 60% were about a 4. So there's that. Even among experts, there was, even within our group, Erin Krebs, I'll show a study that we were involved with her on. She's a 2, I'm a 4. So even within the same family, you'll have that somewhat different philosophy. Came out with some recommendations. These are aimed at policymakers and regulators, not at patients and clinicians. We need better reimbursement and access for chronic pain, evidence-based multimodal care. We need to minimize the collateral damage to those already on chronic opiates as well as acute pain conditions. We need to reimburse the added costs. There's a real hassle out there now to managing opiates because of all the regulations we have. It's essentially an unfunded mandate. We need some greater flexibility in dose ceilings and duration. We need access and policies to naloxone and buprenorphine, medication-assisted treatment, and track outcomes of opiate reduction policies. What about non-pharm treatments? This was another evidence-based review by Chow. We have a bunch. And the push is to use more non-medication treatments, which we should do, understanding it's probably by itself not the panacea, but it's important. First, you have to understand that some of these are active, but that means the patient has to do some work, okay? And which means the same thing when we try to have people lose weight or quit smoking. So understand that the patient has to do some work continued for any of these active treatments. The other things about non-pharmacologic treatments, which again, I'm a proponent we need to use more, is evidence standards are not quite as strict as FDA. It's harder to get a perfect placebo as it is with drugs. It usually requires multiple sessions and, more importantly, patient motivation and work. It's not superior to analgesics. They're probably equivalent. And we really have a shortage of workforce right now in this space, as well as variable reimbursement. So as we move towards non-pharmacologic treatments as a first and foremost part of the menu, we have to sort of deal with some of these issues as well. You've got to have one slide on cannabis because that's sort of the new kid on the block. Just as long as you understand that it is also being treated as a panacea for almost everything. Okay. Now, the good news is you're not going to die of an overdose. Okay. I mean, the worst is you become a stoner, right? And that's about 10%. So 10% of people get habituated to opiates and 10% of people to cannabis. But you're not going to die. We're not going to have 20,000 deaths related to cannabis-related mortality. So that's a good thing. But what about its evidence for efficacy? 27 chronic pain trials, low-strength evidence, except for neuropathic pain. There are some harms that are done in population studies. And most trials are short-term duration. These are not been used for years in chronic pain. And most of the trials have been done with the synthetic FDA-approved cannabinoids and not the stuff you eat in brownies or smoke. So the variable amount that you get in is going to be different. And results are similar. So there are cautionary notes written because this is now becoming widely available. I suspect there will be millions of people use it just as long as you understand the evidence is probably not even as great as we have for approved drugs and non-pharmacologic treatments. Referral's tough. If I have a tough diabetic, I know I can send them to the endocrinologist. If I have a tough cardiac patient, my cardiologist is happy and willing to see him. These are the people who see chronic pain, but it's a hot potato among them. So any given specialty has a small number that's really interested in seeing a number of chronic pain patients. And then there are other specialties as well. So it's also, a lot of it's going to happen in primary care, and we don't have a lot of access to referrals to help with it. So that we just have to deal with that from a policy issue. So in my closing slides, I think I have 4 or 5, I want to talk about 3 primary care trials that have been done here, not necessarily in tandem, but on the next slide, I'm going to show the results from all 3. They were led respectively by me, Aaron Krebs, and Matt Baer, though each of the other 2 was somewhat involved. So the scope, the space, and the Cameo trial, what were they? They all had about 250 patients. They were all done in veterans. They all lasted a year. In the first, we compared optimized non-opiate medication algorithm versus usual care, and the non-optimized non-opiate regimen was not surprisingly superior to usual care. And then Erin, in her SPACE study, which was published earlier this year in JAMA, compared optimized opiates versus optimized non-opiates, so 2 medication regimens. They were equivalent. So the optimized non-opiates, if you take an algorithmic approach, had on group level as good a benefit as optimizing opiates, and the side effects were somewhat worse than the opiates. And then Matt, he presented this about 3 or 4 weeks ago, his Cameo trial. He compares optimized opiates to behavioral CBT and actually found a modest increased analgesic effect in the optimized opiates group, and he's studying the side effects. So we'll have to see. I wouldn't be surprised if the side effects are going to be somewhat worse. The final trial we've completed recently for chronic pain in a VA study, we compared, and they had to have chronic pain and depression or anxiety. The first arm was automated symptom management. They got 9 web-based pain and mood self-management modules. The second group got that plus a nurse care manager and physician who could make recommendations, follow the patient, facilitate mental health. Nearly 300 patients were randomized in a 12-month trial. Both groups had moderate within size improvements, so both a low resource Telecare intervention and a higher resource had moderate effect sizes. The between group difference as an active comparator study was smaller, so that's a small between group difference. More people improved and fewer worsened in the CSM group. So this makes the case that an increasing role for Telecare integrative care for chronic pain. In fact, there's 3 other studies that are sort of ongoing in the get-up phase. Andrew Cheville at Mayo Clinic, who we've collaborated, got one of these moonshot grants for pain in cancer to use a stepped care approach with a heavy dose of Telecare for the SPADE symptoms, which is sleep, pain, anxiety, depression, and low energy or fatigue. Tim Platt-Mills at UNC is using Telecare for older adults with pain discharged from the ER. And Mike Bushy, a junior psychiatrist here at IU, is trying to do a pilot study of telepsychiatry for chronic pain and opiate use disorder. 5 ways to increase scalability. This is my last slide with facts on it. This is the only slide from last year I showed when I talked about telecare, integrative care, is I think there's ways we can increase the scalability. We can use centralization, increase the number of clinics or sites covered by one care manager team. We can diversify, increase the number of conditions covered by, so why not cover pain, depression, sleep, instead of just one? We can do more automation, so we can do automated monitoring, prompted adherence, and self-management. We can stratify by having, not everybody gets it, but the people who just haven't done well get elevated up to this telecare model. And we can activate patients to do more self-management and how to communicate with providers. So centralization, diversification, automation, stratification, and activation. So I will return. So obviously I'm hopeful we'll be Odysseus rather than Sisyphus. I would say we started here in 2000 back in Athens. He went and fought the Trojan War, and it took him 10 years. And so I think right now we're sort of at the opiate war phase. That took him a decade. And then it took him a decade of a very circuitous route to get back home. So I'm predicting in about 2035, I hope we're back home with chronic pain using less opiates. I will close with one more modern example. So Edward Elby's The Zeus Story is a short play with two guys sitting on a bench, I think likely in New York City. And one guy asked how to get a bus from here to there. And as it turned out, like many bus routes, it was kind of circuitous, you had to have transfers and all of that, but I love the quote because this applies not only to taking a bus, it applies to taking care of a chronic disease like pain. It probably applies to about 50% of life. And that quote is, sometimes it's necessary to go a long distance out of the way in order to come back a short distance correctly. So I think, and I hope in the next decade or two, we'll get on the bus and get to our destination. So that's the end. And I think we have 6 minutes for questions. Yes.
I have a question on the pendulum slide that you had.
Yeah.
You mentioned how this panel sat between a 2 and a 4. Do you think that was just reflective of the pendulum swing, that contemporary swing to the 0 side? If you had convened the panel in the 90s, would it have just been a 6 to an 8?
Yes. So I think that standard deviation, I think the standard deviation was wider in the 90s. I think it's quite narrow now because there's just so much pressure, both good and bad, not to prescribe opiates. Good pressure not to initiate, maybe some overpressure to discontinue in people on chronic. So, you know, that's where you are. I mean, there's many stories of people with cancer now who are sort of shamed when they get high dose from the pharmacy. And there's people with, you know, very bad trauma who, you know, so there is a pushback on acutely painful conditions and even the use in chronic. So I think the standard deviation is narrower now. Nobody's going to be a 5 or greater, no right-minded clinician. Everybody thinks we have to use it selectively. But that 1 to 2 point difference is quite meaningful because there's a push to universal discontinuation and minimal use of opiates to judicious discontinuation and use of opiates. And sometimes that 2 to 4 feels like a chasm because this expert group, these are people I deeply respect, differ in that opinion. And it is an opinion. It's less evidence, but strong beliefs, you know. Others, yes, Titus.
Thanks, Kurt. Very interesting. Obviously, the opioid epidemic is composed of many, many different substrata. And we are, as far as national and state figures go, fairly successful in decreasing prescriptions in the medical space, prescribing fewer MMEs and so on. On the other hand, we see fentanyl and other street drugs kind of going up quite rapidly. There is a relationship between the two, obviously, but it's not total. You know, you don't absolutely go to illegal drugs if you start on a medical prescription. What do you see as the relationship between those two, and especially being able to address what's happening in the non-medical space?
Some estimates say that the opiate crisis we have, that 40% of that was contributed to by prescribed opiates. And so we certainly, had a huge contribution to the bonfire, no doubt about it. Okay. Now, the bonfire now has a life of its own. And so we have to deal with this enormous addiction issue, which we're doing. I mean, we're trying. And yet we have to deal with the chronic pain issue. So most people in this space, not most people, most people, even the 2s to 4s, agree that we need to greatly reduce opiate use and we need to increase the treatment of chronic pain, which is not so great right now for a variety of reasons, I said. And they probably have to happen simultaneously. So I would say 40 to 50% of the opiate crisis started with prescribed opiates, which means 50% didn't. Right now, there's an escalation of illicit use, heroin and fentanyl. So the bonfire has a life of its own and is probably going to take issues like medication-assisted treatment and a whole bunch of things we're doing socially, separate from what the doctor does by prescribing opiates. Other questions? Yes, Tom.
To come back to the pendulum, where's the right spot in your opinion, and what would it take to get there just in medicine alone, not counting the social issues?
2.5. There is a role, because chronic pain is like cancer, okay? And we use powerful treatments for cancer, but we use them wisely. Now, nobody goes out there and has chemotherapy-induced mortality on the street because we don't sell our cancer drugs. So there's just nothing like it in my lifetime like this that we've contributed to, and yet we have a cohort of 15 million people on opiates for chronic pain. I think we have to handle that group differently than new opiate starts. New opiate starts, I think, should be short for acute pain. We should try other things and probably no longer than a week. We used to give 90 days. We're beyond that. That's going to help. And to get a refill on that 7 days, there's got to be a good argument. So I think we can handle the acute pain and the chronic pain. I think there's probably 5% of chronic pain patients refractory. Even 30 years from now would benefit from adding opiates, but we have to get, so I think somewhere between a 2 and a 3 would be the sweet spot. Right now we're pushed towards a 1, but that's for a lot of reasons. Other questions? Yes.
So the recent controversy about that super powerful opioid that the FDA approved, as someone who prescribes opioids, is there a real place for that? Was it needed beyond making money for pharmaceutical companies?
Yeah, and I don't know, I saw that just come out, and so I actually don't know about that. I am a little fearful. I can say that just because it's a super opiate, it's still an opiate. So I would have to learn more before that started moving front line with me. I mean, if I was to prescribe opiates in those with chronic, I'd probably continue what they have, and rather than move them to the super one. So I'd have to find out about that. We've had super ones before that backfired on us. Yes. And pharma is accused a lot of that. So I just think, so some of that's been caused. I guess one last question, and then I'll be up front if people have others. Brian.
Yes, I wanted to ask, I think in the informatics space, there's been a ton of work where people are trying to either build systems and policymakers then want to force clinicians to look at something like a PDMP before they do a prescription. And then on the other side, in the data science space, there's been a huge drive for everyone to develop all these risk prediction models for people who might go from long-term opioid therapy users to those with opioid use disorder. But as you showed in the epidemiology, the risk of that is actually fairly low. So instead of, given the fact that there's a lot of people trying to work on these things that might end up not being very effective at all, what would you sort of recommend our informatics group may be thinking about doing to sort of support and help get to the place where we're using it more wisely?
Yeah, I think I agree because the prevalence of going on to the serious things is low. It'd be like predictors of suicide and depression, opiate-related mortality for 15 million people. So I think there'd be a lot of noise. So I'd have to look more about the prediction rules. What I would say is, and I'll close on this point, those that are on chronic opiates or starting opiates, there's 3 or 4 things that should make us particularly cautious. Okay, so if they have a history of substance abuse, whether that's alcohol or other drugs, if they're on other controlled drugs, particularly benzodiazepines, if they have severe psychiatric comorbidity. I have some problems because 10 to 15% of people have some depression and anxiety, but I'm talking about severe PTSD, severe major depression. So, or they have a history of misuse. So if I was to use medical record systems to identify targeted people we should not prescribe in or consider discontinuation and really push the patient, would be those 4 factors: history of substance disorder, concurrent controlled drugs, severe psychiatric comorbidity, and any evidence in the records of misuse. Prescriptions from multiple providers. I've lost my prescription, early prescriptions, positive urine drug tests. Those are the sorts of red flags I'd look for to target. Of the 15 million people we should target, maybe the 1 million people we should target first. Okay, thank you.